that's a 5-year project that we're 3 years into at this point. And the focus of the project is to raise the awareness of the importance of primary care, really to patients and families and communities, and in the context of today's discussion, to employers. We're very much interested in a stronger primary care workforce and enhancing the primary care delivery model, but that's all dependent on a payment system and methodology that adequately pays for that kind of necessary primary care. And so we're collaborating with Jed and his group at Employer Advantage Healthcare Solutions and the Family Medicine Education Consortium, and hopefully over time with others. And our piece of this is to bring interested, pioneering practices and ideas to the table to work with Jed about connecting with employers. So in a nutshell, that's what we're about.
Perfect. Thank you, Glenn. I appreciate that. And again, we have others who are with us who are representing the Primary Care Innovators Network. And as the session goes on, certainly any and all of you are welcome to offer observations, supportive, and the like. And so let me open by sort of sharing that there are times where I will lovingly suggest that those of us that would like to see a stronger working relationship between primary care and employers, we're sort of hijacking the primary care model, if you will, the direct primary care model from that standpoint, because the founders of this whole effort were really focused on changing up the economic circumstances under which they practiced medicine in order to be of greater value to the patient population that they're caring for. What we're suggesting is for a segment of the DPC model practices, there may well be an opportunity to work collaboratively with employers in order, and invite those employers, frankly, to make the membership payment on behalf of their covered individuals. But this business model is not necessarily right for all DPC model practices. And that's what we're hoping to explore over the next several weeks as we continue the conversation that we started in Arlington. And frankly, look at expanding the conversation next year at the DPC Summit, where we've heard that, lo and behold, folks would like to spend maybe a half a day discussing it rather than just devote one particular session to it. So again, we may say things, we may talk about things that some folks are not comfortable with who've adopted the DPC model, but we might say things rather that some folks hadn't thought about before, where they can maintain the purity of the model, but nevertheless create greater opportunity for both patients and employers who invest in the health benefits for those patients. So we're going to take some time here, spend maybe about 40 minutes or so with these observations, and then leave enough time for questions. And you'll have a couple of opportunities to post a question as you go along. And depending upon how many, we may actually unmute some folks who'd rather ask their question in person. But otherwise, the easiest way would be to simply post your question as we go along here. So what we want to do is really take a few minutes to really explore this idea. Why would you want to work with employers when you've adopted this direct primary care model? Well, many of us realize that when you set up a DPC practice, you're really interested in getting covered individuals, patients, people to subscribe to your practice, to pay you in advance of care, depending upon which state you operate in. Sometimes you have to make your or collect your membership payment at the end of the month rather than at the beginning of the month. But regardless, the whole idea is to invite people to your practice to have a different type of relationship with you and your care team, depending upon how large a practice operation you choose to work from. But the notion of securing patient populations, one patient at a time, works for some of the DPC model practices, but has proven to be somewhat of a challenge for others. It's important that when you adopt this particular model, that you ultimately get to scale in a reasonable period of time so that you have the cash flow you need, the revenue you need in order to keep the doors open, keep the lights on, and continue to provide this type of medicine. And clearly we all understand that the direct primary care model is truly the alternative to fee-for-service medicine, and provides some important opportunities for both the clinical team as well as those who are patients of the DPC model practice. So when working with employers, it obviously gives you access to the recruitment of populations of covered individuals rather than individual patients, one patient at a time. So it's sort of like you go where the opportunity is, you go where you can then talk to populations of patients rather than engage in other types of activities in order to get the word out that you're accepting new patients under this model. For those who've converted their practices from fee-for-service environments, they often have a population of patients that they try to flip from a fee-for-service relationship to a membership model payment system. But for those who are relatively new to primary care, again, it's important to scale. And so employers give you that opportunity to scale because they represent, again, populations of covered individuals. The other benefit of this, and an important element of this, is it allows you to move toward what the world has been searching for, which is value-based compensation, alternative payment models, other ways of being paid, so that your incentives, your motivations, your opportunity to deliver true value-based care is much greater than it would otherwise be in a fee-for-service environment. So it's often what I refer to as the ability to align care with the needs of the covered individual rather than simply provide care that you can get paid for. The challenge that both clinicians and employers who pay for care have always had is this disconnect that's occurred between what's covered under the benefit plan versus what does the covered individual actually need in order to improve their circumstance. And the reality is, and we mentioned it in Arlington, the reality is that clinicians have been motivated or incented, unfortunately, to provide care that is paid for, and covered individuals, on the other hand, have been motivated to gravitate to care that's covered. And what we have seen is that often there is this disconnect between what the clinical team would like to do to support someone and what's covered under the benefit plan that would sort of motivate the patient to agree or cooperate with what the care plan might be as developed by the care team. So this idea of disconnecting service delivery from payment is important in this sense because it does really drive value-based compensation. And as we meet with employers of all sizes, particularly self-funded employers, this is an aha moment for them as we start to share with them, typically through a pretty extensive data analysis of their historical spending, how, first of all, a level of medical homelessness has occurred where folks don't have a meaningful relationship with primary care because the benefit plan has never been properly designed to promote primary care. And then in instances where there is some semblance of a benefit for primary care, the compensation formulas, the fee schedules, if you will, are so inadequate as to limit what that relationship looks like for folks who actually have a primary care physician relationship. And often you can see in the data instances where folks are not receiving the types of services that their documented needs suggest they should be receiving, but instead are receiving a variety of things that are of questionable value. Again, often because folks are providing care that's covered or gravitating toward care for which there is a benefit. It does also give you, as a representative of primary care, an opportunity to develop this mutual respect for what true value-driven healthcare finance and delivery looks like. It gives you the opportunity to position yourself in your respective communities as a legitimate spokesperson for the way healthcare should be financed and the way healthcare should be delivered. Up to this point in time, as we work with employers, we've identified the fact that their working knowledge of how healthcare could be financed or how healthcare should be delivered is lacking. I mean, their source of information up to this point in time has often been from those in our communities who are not necessarily interested in improving the way healthcare gets paid for or improving the way healthcare gets delivered. It's bad for business for some organizations to actually see things improve. And so for direct primary care model physicians and direct primary care model physician leaders to take a more active role in working directly with employers creates the opportunity for this mutual respect between those who pay for care and those who actually deliver or organize care. And so that's why I think it's important as part of this conversation for those who want to move in this area, that they see this as an opportunity to help contribute to this mutual respect for the finance and delivery of healthcare. It actually can help drive more affordable care at the community level instead of efforts to try to drive change from the top down. What this does is it creates pockets of success at the community level where one or more direct primary care model practices have the opportunity to showcase their efforts as impactful in the way care is organized, in the way care is financed, in the way care is delivered. And then, frankly, through this effort to sort of infect the business community with this particular model, it can help drive more affordable care at the community level. From our standpoint, because of the way we track activities on behalf of the employer, we're able to show the employer, frankly, in black and white terms, what can happen to populations of folks who are cared for in a DPC model environment versus folks who either continue to be medically homeless or whose primary care is still living under a fee-for-service environment. Because we have folks who raise their hand and opt into this particular model. We then also have a so-called control group who are continuing under the old arrangements or old models, and it gives the employer the opportunity to see what healthcare looks like as it makes this transformation from what's often known as wasteful and low-value care to more efficient and effective and ultimately more affordable care at the community level. Now, when we start to really hone in on what the employer's perspective is, what we want to know is what are they thinking? And it tends to be fairly straightforward across the board. Now, their level of animation in these areas will vary depending upon who that employer is. And that's part of what we offer, is not just to evaluate which primary care appears to be correct for an employer, but frankly, which employers are really ready for this and want to make a commitment to this. It's one thing to talk about wanting to offer a more affordable and higher quality health plan. It's another thing to be able to make those internal strategic decisions from the employer in order to make it happen. And so, generally speaking, employers, they do want to offer their employees and their eligible dependents high quality, affordable fringe benefits as a recruiting strategy, as an overall compensation strategy, and they want to be the source of sponsored benefits, but they want to be the source of sponsored benefits they feel are affordable and cost effective. And then often what they do as a complement to what they sponsor, they want to make themselves the conduit for employee paid or voluntary benefits, as it's often known. And there's a variety of these, but what they want to be able to do is offer something that is well organized and complementary in what they do. And I know in some instances that they've actually looked at the direct primary care model as part of employee paid or voluntary benefits, but often that's not robust enough in order to really make sure that everything is working in harmony. Now, they want high quality, affordable benefits because they genuinely see the need to invest in a healthier and more productive workforce. And so there are, hard numbers that are easy to point to in terms of claims expense, but then there are softer numbers that employers are starting to explore ways of trying to measure, such as absenteeism and what's known as presenteeism, which is the employee is actually physically at work, but their mind is somewhere else, either based upon a behavioral health issue or a physical health issue that is compromising their level of productivity. And then more often, employers are starting to make the real connection between the health status of an employee and the tendency of that employee to be hurt at work, and as a result, create now a workers' compensation type of claim or circumstance. Early in our process of interviewing employers, we discovered, lo and behold, there was an employer who maintained an inventory of standby workers who were, in order to ensure that their production force was properly staffed. And their feeling was, and frankly, the data supported what their feeling was, that they had more standby workers than they really needed, only because the health status of their entire workforce was so impaired. And as they continued to describe their circumstance, lo and behold, they had a physician in their community who was not really helping them because he was quick to certify people as disabled and not able to work, because that's where, from his perspective as a clinician, that's where the business opportunity was, that's where the money was. And so this is genuinely an opportunity to change the mindset of the employer, to recognize that the primary care community in particular can be viewed as more of an ally and a support service than simply an impairment to their ability to operate a successful business. They also want to make sure that they maintain balance in terms of overall overhead expenses, and offering health benefits is often the second largest spend category, second only to salaries themselves for employers, and so they are increasingly becoming aware of that and looking for opportunities to address that. Now, a little bit of history. There are over 800 employers nationally that offer some form of on-site, near-site clinic arrangement because of a perception that local community-based primary care is either not willing or not able to collaborate with them, so they needed to go out and invest in their own primary care. The most dramatic example of this are the Rosen hotels in the Orlando, Florida area, where they have been providing their covered individuals with their own employed physician for over 20 years, and but largely at the expense of the medical community that, as it exists in the greater Orlando area. Other employers have offered on-site, near-site to a limited number of the individuals, either just the employees or possibly just the employees and the adults, the adult dependents. But again, this whole conversation is a perfect opportunity for the employer community to learn to develop a completely different working relationship with community-based primary care. The employer expectations of the healthcare system, it's great to expect things. It's often not what you find when you're out there, but their expectations of the healthcare system as it exists in their community is one that is efficient, effective, affordable, offering quality care. Well, what they've discovered, lo and behold, is something different. They would also like to have a non-adversarial economic relationship with the healthcare system in their community, but often what they discover is something that is different. You know, in my travels and in my experience, I've seen some pretty interesting things that invite, frankly, primary care in particular, but physicians in general, to step forward and offer themselves as the strategy to fixing what's wrong in the different communities as far as the way healthcare is both financed and delivered. And one of which is to be aware of what happens inside healthcare systems, to not necessarily be apologetic for it, but to be able to step forward and offer solutions to it. Part of our data suggests that often more care is delivered than is suggested based upon the documented needs of the patient population. And often it's because standing orders have been created inside hospital systems that deliver more care than is suggested based upon the needs of an individual patient. The reality is that nothing happens to a patient unless a doctor writes an order for something or signs an order for something, even if that order was created through some other means. And what employers would like to see is an environment where the physician is now working in a more collaborative way with them. We sort of suggest it's designating the physician as the purchasing agent for the employer in order to address some of the shortcomings that we have seen in the way healthcare is presently being financed and delivered. And so it is the right kind of physician and the right type of relationship with an employer who can overcome to some degree and mitigate certainly some of the impact of inefficient care delivery, ineffective care delivery, and economic environments that favor the healthcare system rather than support the needs of that particular employer. When looking at working with employers, it's important to put the role of the carrier or claims administrator into perspective. What is their role? What are they supposed to be doing? And what are they presently doing that may not necessarily be as valuable as folks would otherwise believe. And so I often describe it as it's an opportunity for them to handle someone else's money. And this is the case whether it is a self-funded group or a fully insured group, in the sense that the money originates with the employer. It's either paid in the form of a premium payment for a fully insured employer, or actually the claims administrator, the carrier, has access to that employer's bank account and is drawing the money directly out of that employer's bank account in the case of a self-funded employer. Our next session that we're going to have is going to go a little bit deeper into the difference between self-funded and fully insured. But the bottom line is, when you look at the claims administrator or the carrier, it's simplistically, they are handling someone else's money. It's the employer's money, again, either through a premium payment or direct withdrawal from their bank account. The carrier and claims administrator will recommend a standardized benefit plan. Now, that may not necessarily be properly aligned with the needs of those covered under the benefit plan. When we started this whole conversation back in 2006 and launched the first employer advantage style program with Cornell University, we discovered what was then called the Cornell Program for Healthy Living. We discovered the unbelievable level of misalignment in the way the benefit plan is set up. And it took our work group of primary care physicians to be able to articulate it effectively, so that the benefit people at Cornell recognized that their unmanageable and unaffordable benefit plan was of their own doing. It was based upon the way it was designed. And so the value of this particular model of having direct primary care model physicians talking directly, if you will, to employers, is that opportunity to really pick apart that the recommended standardized benefit plan is easier for the claims administrator than it is of value to the employer or the covered individuals. The carrier and claims administrator is responsible for producing the subscriber plan document, which is the document that the subscriber, the covered individual, is supposed to refer to in order to better understand their plan. It's written from the advantage of the carrier or claims administrator. Rarely is it written in order to support the individual needs of the person covered by the plan. They also produce the ID cards. Now, frankly, here's where we start to talk about things that are really of value for the carrier, for the claims administrator. Producing those ID cards, that's important because it helps someone recognize that they genuinely have some semblance of coverage. They do provide customer service. The question is, how effective is the customer service in helping the covered individual understand their plan and use their plan effectively? They arrange the so-called PPO, Preferred Provider Organization networks, or what I refer to as the less than retail arrangements. There's a lot of question out there as to whether or not those so-called PPO networks are of as much value as they could be, because often the so-called savings arrangements are either overstated or misstated, and often don't provide the kinds of financial terms and conditions that folks think. For example, we have seen wild variations in what a particular service might be paid in a given community. MRIs tend to be pointed to often as ranging from anywhere from $500 up to $5,000, depending upon where the service is actually provided. So the other important piece to understand is, what role does the broker or consultant to the employer serve? And I tend to be somewhat, well, I'll just leave it there. They generate commissions. They are a trusted advisor to the employer to the extent that the commission structure supports what they do. They channel various programs and solutions, not always in a well-coordinated form and fashion. So when talking to a broker or consultant, for example, and expressing interest in having them introduce you to employers, keep in mind that you might be competing with something that they already offer to an employer, or you might undermine the financial benefit to them of something that they already offer to an employer. And so those are insights that are important in how you position yourself in a community. They are supposed to provide, and they're supposed to advise regarding the benefit plan design with the idea of making sure everything works well together. But as we've seen in the past, that is limited by that broker or consultant's level of understanding of how things work, as tempered by what their income opportunity is for those various programs and solutions. They ultimately are responsible for shopping the plan, which frankly they do rather frequently. Rather than trying to fix the plan, they tend to shop the plan. We try to suggest to an employer that if you're working with the correct community of primary care, you may not really need to shop the plan at all, because if that correct community of primary care is able to support the covered individuals, then the cost of the plan may naturally come down without having to unnecessarily shop the plan. So as we move to finishing up in terms of prepared remarks, one of the questions that we get more than anything else is, what's the best way to approach employers in a given community? Because in order for this direct-to-employer model to really work, the direct primary care community of physicians needs to have a better business-to-business sense in how they approach employers, and what's the best way and what sort of messaging should be coming to employers. Well, one of the things that we suggest is, if you're a direct primary care model practice and you genuinely want to be working more collaboratively with employers, you need to consider yourself a business first and foremost, and weave yourself into the fabric of the business community. You need to be seen where employers are seen, and you need to be part of business conversations in your community. Some of the more historical or obvious opportunities are what are known as service clubs, like Rotary, or a Chamber of Commerce, for example, or a city club. If your community has a city club, you want to heighten your profile through these avenues, because this is where you're more likely to find local business leaders who would be in a position to evaluate what you'd like to talk about, what you'd like to offer, what you'd like to do. And these represent non-traditional environments for that. And often these organizations are put together both, yes, to be of support to the community, but also because these become great places, frankly, to talk business and look at improving the overall economic circumstance of a given community. And then if your community is fortunate enough to be big enough to have a business coalition on health, then you certainly want to look at joining that. And as much as possible, you would like to join the business coalition as an employer yourself, rather than as a vendor. You want to make sure that the business community recognizes that you yourself are a business, and that you yourself are trying to operate successfully, and that for yourself and for your own employees and their covered dependents, that you too are interested in healthcare in your community that's more affordable. We're fortunate in that we are working with truly a forward-thinking hospital system in Ohio that is able to see itself as an employer first and hospital second. We invited that hospital system to join us in Arlington a couple of weeks ago because they went from exploring simply creating on-site clinic capabilities and offering those to employers to actually adopting the direct primary care model for themselves as an employer first, and are now starting to add local employers to this business model. And so it's what I often refer to as a hospital that's able to see itself as an employer first and hospital second. So if you are fortunate enough to have a business coalition on health in your geography, we would strongly suggest that you look at joining that coalition, but seek membership as an employer, not so much as a primary care practice. And then find the correct broker or consultant who appears to be driven more by service to the employer rather than commissions from the employer. And the good news is there is, just as there is, as I call it, an emerging breed of the correct community of primary care, there also appears to be an emerging breed of the correct broker consultant who is prepared to make this transition from strictly a commission-driven existence to one that is fee-based for themselves, where the employer sees value in the solutions that they are bringing to the forefront, and in particular solutions that are driven by primary care, and in particular the DPC model. Finally, maintain a profile for yourself. Find a way to blog and message around the benefits of primary care, but in particular the direct primary care model. And certainly these are areas that we can help with, because we can give you the kind of messaging that you could be the author of in your particular community. So at this point, I think, Greg, if you could help me in terms of organizing some of the questions. I've been looking at the chat window at the corner of my eye, and it's fast and furious out there.
You've got a couple of questions, Jed, and we'll take questions from the floor as well. Anybody that wants to, if you're logged into a computer, you can simply click on the microphone button and it will unmute you. If you're on a telephone, you can press *6 and it will unmute you so that you can ask a question. But there are a couple of questions already, Jed, that have been posted in text. The first one was from Rudy Kaufman. The question is, what are the legal implications of a physician taking on the role of a purchasing agent, and would they need to be a licensed insurance broker?
Absolutely not. It really is the physician who is making the commitment in partnership with the employer that for the cohort of patients that they are caring for, that they are ready, willing, and able to ensure that their cohort of patients receives care that is properly aligned with their patient's needs when they're inside the four walls of the practice. But outside of that, it's a practice that's able to demonstrate that it has done its homework and it understands where the most effective and efficient specialty care is available, facility care is available. And again, these are the types of support services that we organize on behalf of primary care, make sure that primary care is well versed on. We are exploring new strategies and solutions every day. Had a rather significant call, as a matter of fact, yesterday with an organization that we're going to be partnering with. So it really is it's more of a commitment that you're making than it is any sort of broker or consultant role. It's basically saying that when it comes to care management, care coordination, we're going to avail ourselves as a primary care team of the best possible information to ensure that the services that our population receives are truly in the right place, right time, in the right setting.
So may I ask, is this a term of art or a legal term, or what does it mean?
It is a term of art that is taken from employers, and it's taken from employers, and it speaks to any other vendored relationship that the employer has, where they will designate someone as the purchasing agent for a particular service or supply. So it is not intended to be the purchase of insurance, it's the purchase of healthcare. And our message to the employer is when healthcare gets provided, healthcare gets arranged, you want a licensed physician on your side of the table. So it really is more of a term of art from that standpoint. But it's an aha moment for employers, because often they're buying a vendored service from an unlicensed company around either disease management or care management, care coordination.
Okay, Jed, you have a second question that's been posted from Cameron Sultani. What does it mean for a broker to shop the plan?
Well, and it's an exercise that the broker goes through typically during the so-called annual renewal process. The incumbent claims administrator, carrier, insurance company, typically 90 days, 60 days prior to the expiration of the plan year. So if you can imagine around October 1st or so, the carrier will issue a set of rates for the coming year. In the case of a self-funded employer, it's a budgetary number. For a fully insured employer, it's a premium rate. And depending upon what sort of rate change is occurring, what the broker or consultant will do as part of the process of introducing the new rate to the employer is they will take the employer's demographic information and some semblance of claims history and present it to one or more, typically 3, alternative claims administrators. So if the employer is currently with Blue Cross Blue Shield, then the broker or consultant will invite Aetna, United Healthcare, Cigna to bid on that employer's book of business. And so that's what shopping the plan really means. And often they'll do it in either to legitimize the rate increase that they're about to present, or offer that there is an alternative plan that is willing to charge less, but we may well be back in the same situation. But right now, it's the only thing brokers know how to do, and they often do it from a defensive perspective in order to make it look like they're not just sitting back in a passive fashion. So they have these mechanisms, and some are highly automated, that allow them to get quotes back from alternative carriers in 24 to 48 hours. Some of these are even online systems that allow them to shop the plan.
Okay, a reminder, if anybody wants to ask a question, you may unmute yourself by pressing the microphone button on your computer or pressing *6 on your telephone. Jed, a third question from Lauren King is, can DPC be provided by small employers 2 to 50 as an HRA benefit?
Yes, they can. The only area of limitation right now, based upon IRS rules, are health savings accounts. But a health reimbursement account is simply money that's been set aside by the employer for the covered individual. So yes, an HRA benefit does work for this. The only thing that's right now limited is the so-called HSA benefit. That being said, we have, as an organization, we've actually come up with language that fits the IRS definition of disregarded services that has allowed high deductible health plans with HSA benefits the opportunity to offer a broader range of services under the DPC model in the areas of wellness, disease management, and care management, care coordination, in addition to preventive care, obviously.
I have no other questions at this time, Jed. If anyone else has a question, they may unmute and ask.
This is Rudy Kaufman again. Quick question about the framing of a lot of what you're doing puts the DPC practice in a role where they are overtly selling themselves as advocates on behalf of business, which I would note has a considerable ethical implication for our work with patients. I absolutely agree there's space to talk about effective delivery, but I'm a little bit nervous about the way you're framing this. Can you talk at all about how you interact with patients once you've decided that you're championing the business instead of the patient?
Well, it really, Rudy, is that opportunity to find the aligned, enlightened self-interest of both the employer and their population. We like to think that the employer genuinely wants what's in the best interest of the patient. And if that's indeed the case, then this actually is a terrific business model. If, however, there are employers out there who are not, then those are not employers that would be conducive to this particular model and strategy. So in the same fashion that we help employers understand that there is a correct community of primary care that they genuinely want to work with, we also suggest, frankly, that there's a correct community of employers that primary care wants to work with. And so, there are instances, unfortunately, where the working relationship between the employer and their employees is not the best. And one indicator of that, frankly, is our high rates of turnover, where turnover rates for an employer are actually viewed as a cost containment strategy. And so again, this is not right for every employer and not appropriate for every employer, because frankly, the employer's motivation is misplaced. And I don't know if that helps me or not, but
it's actually,
this is not.
That's actually quite helpful. Thank you. That level of selection would actually make a difference. Could I ask one other question, kind of because it's too tied together? What is your source of your revenue stream relative to all of this? Are you providing a service related to this? And kind of secondly, would you be able or willing to share your information regarding the cost savings that happen between your control group and the DPC practice? Because that would be quite helpful for me as I went and talked to employers to show them at least other examples where this has happened.
Yeah, ultimately, Rudy, we're a vendor to the employer. So the charges we make are one the employer can reconcile in terms of what they're trying to do. And yes, under the right type of circumstances, which is one of the reasons why we joined the Primary Care Innovators Network, is to begin to make data available that validates the model. But in order for the data to be of value, we have to have the correct circumstance or the correct environment for this business model. As I mentioned earlier, an employer with high rates of turnover, this is not good for. So, but yes, if we are a vendor to the employer, and we are very interested in sharing the data because we want to perpetuate the model. It's good. It's good for communities, frankly.
Wonderful. I'll keep going after a break here in case anyone else wants to say anything. I have a few other questions.
Just to let everybody know, the call will be actually ending in about 1.5 to 2 minutes because there's another scheduled webinar that Jed has to move to. If your questions didn't get answered, I'll be posting his email address so that you can send those questions to him afterwards, and you can actually, if you want to reach out to him directly, you may do so. But Jed, there was a question that was posted around what are your thoughts around wraparound HI plans coming more available in the future? Right now, my struggles are with what is the best plan to use with our DPC program for employers and patients to see the most value.
Well, and again, that depends upon both what you offer as a direct primary care model practice and what the employer presents that they need for their population. Some practices have a much wider array of service offerings. Other practices are frankly pretty small, micro practice style. So, but really what we're trying to do is suggest that primary care is a core service, and the standard benefit plan then wraps around that core service. And again, the offering will depend upon what's available as a core service.
There may be time for one more question.
Any final thoughts from anyone?
Okay, I have posted Jed's email address in the chat for everyone to see, so hopefully you can get that one. We appreciate everybody's time today and in the call, and thank you for your time. You can reach out to Jed if you have other questions. Thank you very much.